Hi, I'm Dr. David Frankel from the Hospital of the University of Pennsylvania. I'm here today with Dr. Aneesh Tolat from Hartford, Connecticut, and we will be talking about inHEART. So Aneesh, welcome.
Thank you, David.
Why don't you start by telling us a little bit about the EP program at Hartford, what sort of cases are you doing, how many VTs, et cetera?
Sure. So the program at Hartford is a 10 electrophysiologist program. We have 3 EP labs. We cover much of the state of Connecticut in our program, and so we are a tertiary referral center as well.
That's great. And in terms of ventricular tachycardia ablations, are you doing ischemics, non-ischemics, epicardial? What's your case mix like?
Sure. Yeah, we do about 40 VT ablations a year, about 40 PVC ablations a year. We do the breadth of endocardial, epicardial. We do about half ischemic, half non-ischemic VT ablations.
Fantastic. So very representative of what electrophysiologists across the country and world are coming up against. And so what we're discussing today is the value that you found in the inHEART models in terms of helping you succeed in your ablations. So why don't you start by telling us how you think it helps you get good results?
Absolutely. So we were actually the first commercial site to launch inHEART in 2021. And we've basically started using imaging guided ablation in all of our VT cases. And we found it immensely helpful. We basically get the CT or MRI, depending on the type of pathology that we're dealing with. And then we send that to inHEART, bring it back into the electroanatomic model, and have found that to be really beneficial in many ways that I'm sure you'll get into.
Yeah, let's dig into all that. So when do you find the CT most helpful? When do you find the MRI most helpful? Once you get these images, how long is the turnaround time for the models to come back from inHEART?
Sure. So for the CT imaging, we generally reserve that for our ischemic population. As you know, thinness and thinning is correlated well with the ischemic and post-infarct patients. In the non-ischemic population, we tend to favor MRI. We use the delayed gadolinium enhancement as a way of looking at where scar is. The process and the turnaround time is actually quite fast. We've had patients where we've had them come into the hospital and we've been able to turn around a VT ablation with inHEART in 24 hours in some cases, so very fast.
Excellent. So next let's talk about what's your process for merging these models that come back from inHEART with your anatomic map from the lab.
Sure. So we generally, once they're sent out, and that's actually a function of our radiology department, they're anonymized and sent out, and once they come back onto the portal and the server, our mappers tend to bring them down into the system. We actually use a couple of different ways to register. We use the aorta if we're using sound, ultrasound. If we're using catheters, we can use the PA and other large vessel structures to help guide and get our registration proper.
Got it. Okay, so those are some of the logistics for the how-to. Now let's get into the value that it's adding during the case. So can you give us some tangible examples of how merging with these inHEART models improves your procedural efficiency, effectiveness?
Sure. Yeah. So the things that we see that are of real benefit are that we don't spend as much time creating a map, a voltage map or a high density anatomical map. We rely on the imaging to do that for us. In addition, we also focus on the scar on the image rather than just the voltage. And as you know, endocardial voltage, unipolar voltage, bipolar and unipolar, both can be sometimes a little subject to some interpretation. And so combining the imaging with the voltage is really what we see as a real leverage of imaging.
And would you say that generally speaking, this is going to push you to ablate additional substrate? In other words, substrate that you identify through the CT thinning or the delayed gadolinium enhancement, and maybe because it's mid-myocardial, you're not picking it up on the voltage map, but you may go ahead and target that additional substrate.
100%. Yeah, no, that's what we use to guide it, and I think, as you know, that sometimes you don't have enough information just on the electroanatomic map, and you need that imaging to guide you.
Great. Let's talk about two other specific scenarios. Have you found value in channels identified through imaging as being useful ablation targets?
Sure, yeah. So channels with imaging, especially on the CT, can really be leveraged to help guide and understand where the circuits are occurring. And so we do generally use that as a way of trying to ablate and attack the circuit that we understand in the lab.
Okay, great. On the epicardium, of course, before you ablate, you need to define your coronary angiography. You need to make sure you're not adjacent to the phrenic nerve. So is the segmentation of coronaries and phrenic nerve from your CT scan or from your MR reliable enough that you do not feel the need to perform coronary angiography during the case?
Sure, yeah, that's a great question. I think it's very reliable. I don't know that you can be within a few millimeters and feel comfortable, but I think that if you're at least a half a centimeter away or maybe even a centimeter away, you can certainly feel comfortable. I have. We haven't had any untoward experience with that. Of course, you know, we would always err on the side of caution.
Yeah, and then for the phrenic nerve, you're going to pace regardless because
Absolutely.
it's so quick and easy to
Yep.
do. That's great. There, of course, is a lot of building excitement around SBRT, so radiation-guided ablation. Have you found any use of inHEART in the context of SBRT?
So SBRT, as you know, is still an off-label, new technology that we're looking at. We have used some of that to guide, just like we use it to guide VT ablation in the lab. It is something that I think might be potentially useful to guide us in the radiation oncology suite. And so yes, we did one patient in December where we used some of the imaging from inHEART to leverage and really look at that.
That's great. Getting to results, do you have either published or just the group's collective experience in terms of improvement in outcomes, procedural duration, acute success, long-term success? What are you sort of experiencing as a group?
Sure, yeah, so we don't have any specific published data. However, we have noticed a drop in table time. And so there are about 4 or 5 of us that do VT ablation. We've seen that dramatic drop. We've also had less, I think, in the way of complications as a result. And if you look at our success rate, and I just recently did this as part of our own internal grand rounds, with drug, we're looking at still some 80% success at a year. And we're part of the IVTCC, and so we track our follow-up data as well.
Fantastic. I think one question that people ask, it's quite well established the importance of imaging, pre-procedural imaging, doing your homework before you get into the lab, being as prepared as possible, and so that's going to mean understanding the substrate, looking at the VT morphologies when they're available on 12-lead ECG, and then coming up with a game plan to enter the lab so you know what chamber to start in, and are you going to go with sedation, general anesthesia? So if someone asked you, what is the incremental value beyond getting your MRI, looking at the VT ECGs, integrating it in your mind, what is the incremental value of the inHEART models? What would you say?
I would say the incremental value is the registration piece, where you can not only, you can look at an MRI on a computer screen and say, okay, well, I think it goes to the top of the septum, but it's actually having that registration so that you can actually put the catheter to where you see it on MRI and use that registration to really leverage that.
Fantastic. Is there any memorable case that comes to your mind where you found the inHEART model to be particularly helpful to you?
We did a case where we actually ablated a VT in an ischemic patient who had no groin access. And vascular surgeons said no. And so we actually got the surgeons to come into the lab. We did a cut down into the brachial artery. And we came in through the brachial artery, through the retrograde approach this way. And then we used inHEART imaging to help leverage that image-guided approach because we didn't want to spend too much time trying to create a whole reconstruction. And so, yes, I think that certainly was a real help in terms of the case.
Yeah, I would imagine cases where vascular access is limited in any capacity, whether it's interrupted IVC, you're not going to be able to get as many of your preferred diagnostic catheters into the heart. The more information you have to help, the smoother the procedure is going to go. Do you have any tips for people who are interested in starting to use inHEART in terms of workflow or procedural pearls that you'd like to share?
Yeah, that's a great question. So I think that the tips are, if you're pursuing or planning to pursue this, you need to have a discussion with radiology about the protocol. You need to have a real chain of command and a process built before you start doing it, so that everybody on the team is responsible for their piece. And so even here at the conference, I've been emailing and saying, has that scan been done? But we have people in the pipeline who make sure that the scans are done, they're anonymized, they're sent out with the right information, and then they come back and get put into the system. So you need to have all of those pieces put together.
Got it. Okay. Well, thank you very much for an excellent
Great.
discussion.
Thank you, David.
And enjoy the conference.
Thank you. You as well.